Prescription drug abuse obviously is a really bad problem. We started looking at this data really back in around the early 2000s. Some pretty interesting data was published, 2002 National Survey of Drug Use and Health in ages 18 to 25. Prevalence of lifetime non-medical pain reliever use really started hitting home to us. So it's 6.8%, 92 to 20% by 2001, and by 2002, 22%. And it gets worse. So we looked in 2003, National Institute of Drug Survey of 12th graders. By the way, are my current medical students, and it answers a lot of questions, just so you know. Non-medical use of medications, 10.5% used Vicodin, 4.5% used OxyContin. Now here's an interesting, we talk about hydrocodone or Vicodin. The DEA, I actually did a joint program, actually at the medical school with the DEA, of New Jersey, and they stated a very scary statistic in their presentation, so I'm quoting them, and they said currently 2/3 of all the production of Vicodin is distributed in New Jersey. So let me rephrase that. 2/3 of all distributed Vicodin is in the state of New Jersey. So, well, their quote. So I'm thinking legal distribution, but 2/3. So I don't know what that means, and I don't know if, drug company, mail away, I don't know what is all involved in that. It's their data, but this is why New Jersey is very much on this right now. And there's a lot of other scary data what goes on, in all states. I think we all talked last year about Florida. But just a very interesting data. I was shocked when I heard that. Undertreatment of pain, right? This is what we've been told a million times, right? Undertreatment of pain is a serious problem. Effective pain management is integral and important aspect of quality of medical care, and we should treat it aggressively. And for many patients, opiates are the most effective treatment. And so we were told that, and not only were we told that, but we were told, listen, pain is the fifth vital sign. And then what happened, and I'm going to go into this a little bit more, which puts us into the history of today. How many people here do hospital management at all? A little bit, right? So in order to stay in a hospital, right, what is it that you're judged by right now? Quality indicators, right? And patient satisfaction is one of them. And they looked back at the data, and they found out that patient satisfaction data, which is markedly linked to pain management in a hospital, which thank God it is in a way, but what comes first? If I don't give them what they want, right, or I don't give them more, then they're going to give me a ding, and then I'm going to result, and then that's problems, right? And ERs particularly were hit by this. So, and they know that. So I'll get into that in a little bit. So again, we're all afraid. I think this is a great slide right now. I've shown it before, but I really think now this is where we are. I think now with all these regulations coming out, we're now very fearful of what could happen to us as providers. And it's probably going to, and it already has, resulted in an opiate decrease because of fear. And it's just the reality of when we put out some statements like the CDC did. But I think those of us who are providers here really want this, right? We want to make sure that our patients are treated appropriately for their pain, but we want to eliminate and take away abuse the best that we can. All right, so getting back to U.S. statistics, right? So even back in 2001, and I'm going to go through the Dawn data in a minute, but 2001, 7.1 use illicit drugs, 1.4 are dependent on or abuse drugs, 20.6 abuse alcohol, and 29.5 use tobacco products. Now, it's very interesting. Have you guys looked at the tobacco data recently? Because this is what I do for fun, right? Like, what are people smoking now? So, tobacco data, for the first time in our history, this past year, tobacco finally went down. So for the first time ever. So it's very interesting to see that. So Dawn data, so what is that? The Drug Abuse Warning Network. Now the Dawn data is all the stuff that we're talking about, that's being talked, that's put out in that the CDC has looked at. Not only that, but but every television I was watching, what's Channel 10? Whatever. Channel 10 Evening News, World Report. And every day last week, if those of you have seen it, they've talked about the U.S. opiate abuse problem. Right? Every day they talked about that for a week. So it was very interesting to see that. And they had some doctor get up there and say, I don't know where they got this person from. Really, I really don't know. And he'd be like, well, how many people do you give opiates to? 100%. Do you think that's a good idea? Not really. Like, you're on national TV. Like, what? Right? I honestly didn't know where they got this person, and it made the profession, thank God it was allopathic, not osteopathic, but it made the profession look really, really bad. And he'd be like, well, everybody came in work injury, and oh yeah, everyone paid cash, and all this stuff. And you're like, whatever state he's in, they're like going on their prescription monitoring report and seeing what he's doing. And I didn't, and it looked like, did you ever drug test anyone? No, we don't really do that. And he's on national TV. Has anyone seen this guy? He's in, I know. They're like, thank you for doing the TV show. The police are waiting for you right now. So when we look at Dawn data, it was never meant to be the scientific measurement of what people are abusing. It was never meant to be that. And let me explain why. And I've said this to you guys before, that every ER tests different things. And a lot of ERs don't even check what we call synthetic or semi-synthetic opioids, right? So they don't check them. So they're only looking at morphine-based products. And where I'm in South Jersey, that's the far majority of the ERs. They don't really even check other stuff. So, and it goes back to the day when the only thing people were ever abusing were heroin, which is morphine. So they only checked for morphine. So, so the Dawn data is, the purpose of it was, so if you're in Philadelphia and you're mixing marijuana with let's say, fentanyl, South Jersey's going to know that, so we can now look for it so we can save lives. That was the purpose of Dawn data. It was never to be a scientific measurement of what people were abusing. So as for lots of reasons, it's just not good data, but it's what we got, and it's what everybody's quoting now. So we'll go through this a little bit at a moment so you can kind of get to where we were. So back in 2002, oxycodone and hydrocodone were the most frequently named pain relievers, about 40% of ED visits. And then we get by 2004, you can see that our far majority of drugs that people wanted were the Percocets, the Vicodins, Lortabs, Tylenol with codeine. So these, right, and I think we won't go through it again this year because you've already heard it, but people don't want generics, right? So hydrocodone, like no one cared about that, but if it's Vicodin, it was wonderful. This was the 2000s, right? People had money, you had designer stuff, including designer pills. It was big. So what happened here was people wanted their Percocets. They liked their short-acting agents right now. So in the state of New Jersey, what do you think the #1 street drug is? The #1 desired opiate. So believe it or not, it's no longer Vicodin. It is oxycodone 30 milligram tablets. That's it. They're worth a fortune on the street right now. The #1. Now, the most prescribed short-acting opiate, according to the DEA, is still hydrocodone in the state of New Jersey, because apparently we own that. But oxycodone 30s. So Dr. Jermyn's rule #1, don't write for it. They're looking for it. So, and it should only be prescribed for kind of end of life where this person requires such a very large dose of a potent opiate analgesic. So rule #1, get rid of it, because we got everybody. I run a pain center, and the only people that we have on oxycodone 30s right now are end-of-life patients. That's it. So it's a big red flag when they're looking at, and we'll talk a little bit about how they're looking at us now. So that was in 2004. Right, by 2008, This is when the OxyContin world came out, right? Oxycodone became big, right, because of OxyContin. And then what we found at that time was methadone markedly increased. And the reason for that was this was the transition where people were realizing people were doing bad stuff with OxyContin, crushed snort or injecting it. So they said, all right, well, let's switch everybody to methadone because what could happen with that? Because you use it just for addiction, right? So what we found out, because we didn't know much about it, several things about methadone. One is it's heavily metabolized in the liver, cytochrome system, 2D6 in particular, and it was very, very easily manipulated with other drugs, including NSAIDs. So NSAIDs can manipulate methadone in ways that are scary to most of us. And I do quite a bit of genetic testing now in my office, so and someday I'll come back and give a talk with that if you want. But what genetic testing is, I can do genotype testing for patients and look at their cytochrome system and determine whether they're a good metabolizer, a hypermetabolizer, or a slow metabolizer of these drugs. And this is just anecdotal because I think I'm going to publish it, but the number one drug that is really screwed up in the system is methadone. And so lots of patients have lots of problems metabolizing it. So when people are using methadone just for detox, you'd use it once a day, done, one and done, that was great. But its duration of activity as an analgesic is more like 4 to 6 hours, sort of like a short-acting agent. So people were prescribing it 3 to 4 times a day, and people were legitimately overdosing it. They were not able to metabolize it, and about 4 to 5 days, more people legitimately overdosed on methadone than any other drug prescribed to this day. I don't mean drug addicts wanting overdosing on OxyContin. I mean, when we do an opiate rotation, more people overdose on methadone than anything else. So Dr. Jermyn's rule number 2, don't prescribe methadone unless you're very familiar with this patient, and I would get a genotype test for anybody that you think about putting on methadone because you want to make sure that their cytochrome system is okay and can manage it. Okay, Dawn data in 2010, and this is the data that got out and is being talked about quite a bit. Now, it's been around for a while. I've been presenting this, guys, at least for the last 5 years. So it's nothing new. But what's happened was this revolution that everyone's basically leaving pills and going to heroin, and people are now going back to this. And what happened in 2010, which I've showed you guys before, where illicit drugs was 23.8 and pharmaceuticals went to 27.4. So the first time in U.S. history, prescribed drugs were more in percentage than drugs that were street drugs. And that became a big deal. And it is a big deal. Now, when you look at the actual data, I'm telling you, it's very, very hard. I mean, I looked at this, to even get this was hard to try to figure it out. So this is my own thing. So because there's always someone in the audience that's like, well, break it down for me, Dr. Jermyn. So here it is, okay? There are everything here. And if you notice here, they did that anything that could be sedating was put into that number. So they were benzos, they were sleeping agents, they were anticonvulsant drugs, they were anti-anxiety drugs. They lumped it all with opiate medications to get to the number that they're at right now. So you may or may not say that's meaningful to you or not. When you look at Dawn data, I swear you need to be on something yourself to understand it, because it's really, you do, because it's reported with or with alcohol, polysubstance abuse, which is a lot of it, right? Blah, it just goes on and on and on. So this is my interpretation of it. But I just wanted you to see that when people are talking about prescription drug abuse, they're really not just talking about opiates, they're talking about all of this. And I think that needs to be hopefully meaningful to all you guys. So the CDC came out, right? And they put out some really pretty strong statements. So I would recommend everybody to take a look at this, right? CDC opiate guidelines puts pressure on PCPs to put away the prescription pad. That's a nice way to say how they put out a statement, to be honest with you. Now, the CDC said nothing new. I just want to make that clear. They just said it in a very strong way, probably stronger than I would have expected. But they said nothing new. What they said was that we have to be responsible with prescribing. Now, I just spoke a couple weeks ago at the ACOFP. Anybody went to the ACOFP. Um, yeah, it was in, Puerto Rico. Not that AC this time of year isn't lovely, but Puerto Rico was really cool, uh, just so you know. And I gave this talk out there, and people wanted to take my head off. So I'm not the messenger; I'm just the messenger. Um, and because they were very angry about this, that they felt that primary care were really hit hard with this, and I'm not disagreeing with that. Um, so I think that what went out there, and I think one of the things that we have to be mindful about is now this isn't a public persona. So we have to have these conversations with our patients and our patients' families. All right, how do we get here, right? Well, I'll be the first to say that I had very little pain management. I'm a PM&R doctor. I went through training, and I had very little, even in my training, and it was a few years ago, um, very little about opiate management. Most of it I learned as an attending, as you guys. Pretty much everybody in this room, how many people here feel that your education, your medical school and residency training adequately prepared you on how to prescribe for opiates? Show of hands. Nobody. That's correct. It's a big problem. It's ironic. The number one reason we go to ERs is pain. The number one reason we're called in evenings and weekends are pain. The number one reason people go to doctors is pain. The data's there, and we suck at training young doctors on how to do this. So I'm very proud. Rowan, our South Jersey Osteopathic Medical School, is one of the first in the nation to teach pain management. And I'll let you on a little secret. The dean's not here. I have to fight for that. Well, cardiology is important. Well, so is pain. So I don't know if no, I know it's a joke, but literally when they're looking at, well, where do we put all this stuff? They're like, do we really need 2 weeks of pain? I'm like, yeah, you kind of do. So we've been doing it for 10 years now. So at least our trainees get out there and they're learning about this and they understand this stuff. But the far majority of doctors that are out there have no training in this whatsoever. Minimal to none. And that's a problem. So the president, I don't know if anyone's familiar with this, about a month ago, the president put out an initiative to all higher education systems. Anybody familiar with this? Where he made us take an oath. I didn't understand the oath thing. Where every medical school now has to train people in pain management. And I was actually interviewed by NPR. And NPR called me and they said, well, what do you think about the president's initiative? I said, well, I think it's great because I've been doing it for 10 years, right? I've been training people and we need to do this. And then literally 5 minutes later, I had 3 major medical schools call me and say, we want your curriculum because we have to do this. So we could say that in South Jersey, we're really leading this in medical education. So I am proud of that. However, no one else is. So you want to know the 3 schools that called me within an hour? Jefferson, Temple, and Penn. All my colleagues, Jefferson, Temple, and Penn, all had my cell phone number, my colleagues over there, and said, we need your curriculum like tomorrow. So pretty cool, right? Anyhow, so the DOs do a little bit better, hopefully. So patient satisfaction scores, metrics in hospitals, ER, pain is the 5th vital sign. So if patients feel that they were not treated adequately for pain, they pound us on their patient satisfaction, and statistically, that impacts how we make medical decisions, right? I know it does. I sit on the hospital panels for this, and they sit there and they're like, Doc, if I don't give them what they want, they're going to ding me, and then the hospital's going to have a problem with me. It's a problem. Aggressive pharmaceutical promotions. I lived through the Purdue's and the wars and, we're going to do, give OxyContin for everything. Hypothyroidism, try OxyContin, right? No, it was true. Like, we lived through that, didn't we? I did, at least. So what did the pharmaceutical world do? Oh, yeah, that's why there's no one sponsoring me for this talk, just so you know. No, it's true. So what did the pharmaceutical companies do? Well, they said, hey, what do doctors do not know much about, right? Pain management. Well, let us train them how to do it, right? And that's sort of, so that was very new in history where we kind of learned, and I'm not saying we shouldn't learn from the pharmaceutical world. They're doing the studies. I do clinical trials. I've done opiate clinical trials. I've done quite a bit of them. I've done 50 clinical trials in my lifetime at this part. So I've been involved in that, and I know. So I know the data end of it, but the sales is completely different. So it was very interesting to see what happens, and we look back in history of time, this will never happen again. And then I talked to you guys before about what we have now is known as the pill culture. And those of us who are parents here probably know what I'm talking about, and some of our younger people here remember it, where when we would get up in the morning and first thing we would give our kids would be their Flintstone vitamins, and we would say, take your pill because it's going to make you grow up to be big and strong. And when we did that, we made a culture, young people think, pills are fine. Pills can't hurt you, right? And people believe that. It's amazing to me. Well, if it's a prescribed drug, it's fine. It could never possibly hurt you. And people believe that, right? So, and we're going to talk a little bit about this in the second part of my talk, and that is poor and inaccurate drug testing. So, how many of you guys here do try to do this in your office and you buy those disposable cups, right? And you take the peel off, right? Are they not nightmares? They are living nightmares, right? I did it for many years because we didn't have, I worked with LabCorp and I worked with, what's the other main, LabCorp? Quest Diagnostic. I worked with them on a national level to put together their GC mass spec drug testing that they now have. That's only 2 years old, right? Because I would yell and complain and say they're completely inaccurate. So I made them do their 10 drug panel that they have now with GC mass spec confirmation and drug confirmation, right? So now there's standards that are out there, but that's brand new, right? And no one knows how to interpret them, which is another scary component, right? It's like you get a printout and it's like, what the hell is this? Right? So that's another problem. So again, it goes back to education. We didn't know how to do it. The drug tests suck. I tell you, I remember the day, I cried. The day that we put LabCorp in my office and I no longer had to make people pee in a cup and watch them do it. I have students that do it. I'm like, there's the glamour part of pain management. Go, watch them pee. And they're like, what are you talking about? I'm like, yeah, it's glamorous, isn't it? Welcome to being a doctor. And go in the room. And so the day that we started doing this, and this, I mean, it was revolutionary change for us because we can now have these great tests. And how many of you guys have had, people will turn green in your office before they'll give you a urine? I can't go, right? Now, I'm a guy of a certain age, but not to that age. So I can tell you, I can pee anywhere. I can, literally. It goes back to the day that we would mark our territory, right? It does. We're not that far removed from those days. When a guy tells me who's relatively younger says I can't pee, I'm like, you are lying to me. I could pee right now, right? So it's a truth. Really, every guy here knows I'm telling the truth, right? You can't tell me you can't pee. So, all right. So now, very interesting, though I don't know if you guys have seen this. New Jersey Hospital regulates opiates to the sidelines. St. Joseph's Hospital in a fight against opiate crisis, where now they've come to the conclusion they're going to write no opiates at all, right? I'm not the hospital, right? And then if you read the article, it was fascinating. And they're like, well, if someone comes in with kidney stones, you're going to get IV lidocaine. Okay, anybody here ever have a kidney stone before? Right? Isn't it like someone's reaching up your butt and pulling your nose through it? Going up and pulling your nose through it, right? I've had it. It was the most horrific thing I've ever experienced. I am not going to St. Joseph's Hospital if it comes back again. Now, I'm not arguing that they're not doing something responsible. I think this was an opportunity to get in the news, but But I mean, we need to look at other alternatives, obviously, other than just opiate therapy. But to sit there and say you're going to get lidocaine when you have a kidney stone, I kind of think is a little much. But I'm not the ER doc. But it was an interesting, and he's a kidney stone person. He's real happy. I've never seen a person who's had a kidney stone look like that, even on opiate therapy. My experience, but what do I know? So now we're going to start seeing a lot of data that some of which is actually fairly accurate. And this is so, and I wanted to put this out. The majority of opiate overdoses, patients still prescribed opiates. And this is out there. And so what does this mean? It means that people that have overdosed eventually get back on opiates. And unfortunately, sometimes the same provider is prescribing the opiates, they overdose, and they get their opiates back again. And when the media looks at this, they're like, wow, that's so irresponsible for the doctor. And I'm not saying that there aren't some doctors out there who are being irresponsible, because there are. And however, this is easy to happen. And I'll give you, I think some of you I've told, I try to defend physicians to the state, medical board, and prosecution. So I'm a consultant to them. And I have also rehabbed, I don't like that word, but physicians who didn't know how to do it well, lost their DEA, have spent time with me and got educated and were able to get their DEA back. So I like doing that. I think medical schools should have that service for our physician community. Having said that, I always reminded of a case that I was asked to defend. And it was a horrible case, and it was about a young man, early 20s, living in his parents' house, who was on pretty high doses of opiates, I would say. Probably much higher than I would have been comfortable with, but I wasn't managing him. That wasn't the issue. Patient went into the ER, overdosed, and patient was given, was basically detoxed in ER, stomach pump, the whole bit, Narcan up the wazoo, and then refused to go to detox. Absolutely refused. The family was there. The family drove him home, and happened to have an appointment that Monday to see their family doctor, who had no knowledge whatsoever that this patient was in the ER and basically has been detoxed off very high doses of opiates. And what makes this case even sadder, it was July, and it was the first month that this covering doctor was working. So this doctor was just covering. So unfortunately, this doctor had no knowledge of this patient and thought this was just a routine follow-up. What was very interesting was the family actually drove this person, because he was driving them crazy at home, clearly. And no one walked into the doctor's office and said, you need to know. And the doctor just renewed what was an average dose, what the patient's been getting forever. And then the patient went home that night, took that now very high doses of opiates after being detoxed off, and unfortunately died. So I had to defend that case, which I thought was defensible, and it was. And I've never been, and those of you may or may not know, it's horrible when you defend your license and your medical license, because even if it's your medical board, you go in front of a judge. A judge determines it, by the way, not a medical person, a judge. And you go in front of a judge, and the good thing was the family was in the room because they're allowed to be there. It's an open hearing. And the judge said, wait, I need to understand something. You drove your son to the doctor's office, and you did not even let the doctor know what happened. And the family said yes, and then the gavel went down, and he said dismissed. So that was very, very good, but there's a system issue here, right? The system issue is, think about how this could happen to anybody this weekend, and when you open on Monday and you have patients coming in, how would you necessarily know what happened with your patients? Think about it. This can happen. And it has nothing to do with us doing anything irresponsible, right? So as much as electronic medical records have made all our lives so much easier, like everybody promised they would, right, on Friday afternoon, my whole EMR system went down. So those of you who may have been in that situation before, I wanted to kill myself. But they have not. There's not been one quality improvement with EMR. Not one. Not one quality improvement has been documented since we went electronic. So it's interesting. We thought this would solve all these issues, didn't we? No. No. If we all had the same EMR, it might have been a lot easier, but no, we've got 8 gazillion of them that don't communicate with each other, so this can happen every day of the week. All right. So what are real risk factors for opiate abuse? Obviously, age. The older you are, our 85-year-old ladies, I'm like, ironic, they're always afraid of getting addicted. And I'm like, you're not going to be 85 and now become, on a street corner trying to get your heroin. But I will caution you that our new elderly patient population kind of coined the term, recreational drugs, just so you know. So we do have to start thinking about that. A family history of abuse, personal history of abuse, personality factors like psychiatric disease, bipolar, schizoaffective disorder, family dynamics, and social factors. These are really true opiate risk factors. So one of the other pearl for everybody that's on an opiate, I would highly recommend doing an opiate risk tool. Now, do patients lie on this? All the time, okay? And for the longest time, I just stopped doing them because people lie. But you know what? It's one more thing in your chart that could really help you if you ever, and there's several very good opiate risk tools. One is called the ORT, Opiate Risk Tool, or the SOAP Note Screener and Opiate Assessment for Patients in Pain. They're very simple. This is your opiate risk tool. You'll have my slides. You can just download this if you want. There's the reference right there. They're very good. You just add it up, and it gives you a low to moderate to high risk potential with your patient. So I would highly recommend for all your patients on opiates to get this opiate risk tool in there. And I would do it yearly. We'll talk a little bit more about some of that stuff. This is like killing me, this thing. It's just some basic definitions, just so we know. I had, not an argument, but I had this little lady that came in, and she's been on 10 milligrams of Percocet 3 times a day for literally 25 years for spinal stenosis in her back. And she came in, she goes, I'm addicted to it. I'm like, you're really not addicted. You're dependent on it, and they're two different things altogether. And so dependence is a physiologic, it's physiologic where patients require medication to have a functional level. So if we're dependent on something, if you take it away, their function gets worse, their medical health gets worse. So I always like insulin-dependent diabetes mellitus, right? I'm not as smart as you guys. If you take insulin away from people, I understand, so I hear bad things can happen, right? So that's what dependence is. Tolerance is the physiologic phenomenon where you may require escalating doses to have the same physiologic event. Now let's talk about this for 30 seconds, tolerance and opiates. There's a lot of good data coming out there right now stating that it may not be what we were thinking before, that it might have a lot to do with how we actually metabolize these drugs. So I just want us to think about it. We do become tolerant to bad effects of opiates, a lot of times constipation and even euphoria, but it's interesting that are we really developing the tolerance that we think? So more to come with that as we look at things. Addiction, this is a psychological problem, right? And I like the addiction triangle. There are 3 peaks to the addiction triangle. The top of it is genetics, accessibility, the other peak, and then the third peak is environment. So all 3 have to go bad, like the perfect storm. And of all those 3, the only thing a physician can control is accessibility. We can't control genetics, and we definitely can't control their social environment. Pseudo-addiction are people that look like they're addicted, but they're really not. They're just in pain, and they do addictive-like behavior, like constantly calling for more medicines or going to the ER because their family doctor doesn't give these medications. Diversion is selling, trading, getting, or receiving for financial, sexual, and social gain. And when I tell you the stuff that's out there that people do, you would be amazing. It's amazing. So and that I said, you know, and I think I've told you guys before about the stripper doctor. So we'll move on. Opiate-informed consent, we'll go through that. Opiate patient agreement, you guys will have all of mine. It's been through legal 8 gazillion times. Every year I renew it. Every year I look at it again, and 10 lawyers look at it. Pill counts. Pill counts is where you call your patients up and you say, come in today. You have 24 hours, bring all your pills in so I can see them. And pill counts are unbelievably valuable, and I'll tell you when we use them a lot. Um, and, uh, and the thing about pill counts that you have to be careful about is you can rent pills on the street right now. You can, yeah, it's a business, people. You can rent, you can rent urine on the internet too. Most people don't want it back, but you know, assuming you guys are clean, you're really peeing a fortune away. You really are. True story. You can buy urine on the internet. You can retire. Right, I just said 2 minutes ago, I can pee anywhere. Why am I standing on the stage? I made the joke to my dean, though those of you know Dr. Cavalieri, he and I don't have the same sense of humor. And I'm like, Dr. Cavalieri, I know how we can get better textbooks for our students, you know. So growing marijuana on medical marijuana on the roof did not go far with him. And then my second thing was about, you know, selling urine, and he did not find it funny. But so, in the prescription monitoring report, and New Jersey has the prescription monitoring report. How many people have access to prescription monitoring report? Okay, that needs to be 100%. Okay, so like everything else, money is what makes the world go round, right? So the state invested a huge amount of money, which will probably be turned over to us to maintain it in the very near future. So they want to make sure we're using it. So they're going to start making sure that doctors are using it. And as much as people are saying that the state's not going to get involved and they're not going to be looking at, and we can't, the purpose of it isn't to see what doctors are writing. There's a whole section in the prescription monitoring report that you can actually monitor yourself. And you ask yourselves, why would that be there? So it would be a very easy subpoena to get for anybody. So I would highly recommend that you start using the prescription monitoring report and make it part of your EMR. So, which I know is not easy. We do it. We print out our prescription monitoring report and we put it in into our electronic medical records. So we do it. Now, New Jersey state law says the prescription monitoring report for people on chronic opiate therapy, and my definition of chronic opiate therapy is once you give 3 consecutive scripts of an opiate to a patient, that third script, they're now chronic, okay? And you have to think in those terms. If they're now a chronic pain patient, you need to make sure that 1, you drug tested them, and 2, I would access a prescription monitoring report on that very first opiate script for any patient that you give out. Yes, it's a pain in the butt. I do it myself. Yes, I see patients every 15 minutes, so I'm there with you guys. But you got to do it. They say they're going to make it easier on it. Some of the regulations there say that your nurses can access it for you. Still trying to get some clarification about that because they have to use your sign-on, which is your license number. So I'm trying to figure out the best I can, but this is not coming easy from them. Even when you call them directly, which I do, the Attorney General it's actually this, the Attorney General for the prescription monitoring. Everyone's got a title. And you talk to them, I'm like, well, can you be clearer on what your regulations are? Like, we'll get back to you on that, and no one ever gets back to you. So, but I think that it's actually an incredibly, really good tool. And I'd be amazed at how many people who come into you and say, I swear to you, I've gotten nothing else from anybody else, and out comes the report, and they weren't truthful. And then you walk in, and you say, well, who's Dr. So-and-so? And you're like, wow, I don't know who that is, right? And you're like, well, but you do know who that is. So unfortunately, in South Jersey, where I practice, and those of you know, right next to Camden, the place where they make drug addicts, yeah, there's like conferences like this going on as we speak. Like if you're just dabbling in drugs, you want to learn how to do it really well, just go to a conference like this. It's in downtown Camden. They teach you how to do it. And all you have to do is go to Philadelphia because Pennsylvania is not on the prescription monitoring report. Now, I caught someone just this past week, just so you know, who went to a doctor in Philadelphia and got a prescription, but got it filled in New Jersey. That was stupid. So it did come up on the prescription monitoring report. So, and I'm like, well, who's Dr. So-and-so in Philadelphia? And they're like, well, what do you mean Philadelphia? And I'm like, yeah, it's here. You got a prescription. And so sometimes, well, drug addict, it's all the drugs, I guess. I don't know. So again, if your state has a monitoring report, you have to be using it. So you must have here's the other thing, because I went back and forth with the Attorney General on this. I'm like, what means you have a relationship with the patients, right? So everybody that's coming in, we get records and stuff. I request them from primary care so we can review the records. And at that time, I'd like to pull a prescription monitoring report before they're actually in my office. So so this is more, I guess, on my end than maybe your guys, but you guys see this all the time, right? New patients come in, and you don't know what's going on with them, and so you want to, before they're your patient, you wanted to take a look at the person. So apparently you can't do that. So they must have an appointment with you in order for you to access the prescription monitoring report, or it's a HIPAA violation. Sorry, I didn't make that rule. It's stupid. I know. Don't shoot me. But so now you have to offer them an appointment, and now that's an established relationship. And once you do that, you can access the prescription monitoring report. Right? It talks about the history of the controlled substance of the patient. Pharmacies are under huge regulation for this. Right? Who's the number one people that report doctors to the medical board and the DEA? Pharmacies. And they're pissed about this because you think they're tough on us. They have to, anybody getting an opiate script right now, they have to access it every time. Every time. So, and they have to report it and get that data into when they give out the medications. So I'm not saying they're pissed, but they're not happy. This is a lot of work. So I get that. So when they see these things and they call you, please make sure that they're listening to you, because it's a very quick way of getting information to the DEA. And then, of course, there's an area that you can monitor yourself and your prescribing habits. And I get this all the time. And I'll tell you, I remember this guy. He came in here all the time, grabs me, and he's like, "Oh, Dr. Jermyn, I only have 5 people in my entire practice that have opiate therapy." That was not true. Okay, just so you know. And I get it a lot, so the doctor gets in trouble. And, we're talking, I'm like, are you doing the drug testing, doing all the stuff that I'm saying to do? And then, and he's like, well, I'm not, but I only have 5 people. I should be fine. And next thing you know, I get a call from the attorney saying, can I defend them? And it was like thousands it was like, a crazy amount of people. I'm like, I get that so look at yourself. See how much you actually are prescribing. It might be an eye-opening experience for you. Opiate compliant informed consent, you guys can have mine. They're very they're very, very complete, rather. And an informed consent is like, if you take too much, you can die. If you drive, you can die. If your kids get it, they can die. If you drink alcohol, mix it with benzos, you can die. You got to keep it safe from children, theft, harm, blah, blah, blah. That's your responsibility, not mine. This is really helpful. People get into car accidents with this stuff, and they call you, and an attorney says, I want a letter from you saying it's safe to drive on these meds. And you're like, no, I can't give you a letter for that because I can't say that. And in fact, look, they signed a form that says I told them I could never say that. You're clear. So it's very, very valuable for you. When do you treat with opiates? I bring this up here because you have to be consistent. Right? So when all the measures have failed, and that's what the CDC says, or when the intensity of pain and or the diagnosis requires it. So when people look at your records, God forbid anything like that, they want to see that you're doing the same thing. You've got a system set up on how you're prescribing, and it's not willy-nilly. Now, I would highly recommend, and it's my practice, that we don't have patients just on opiate medications. You have to have them on other things. Adjunctive analgesics. I'm going to say it again, I do not have a patient in my entire practice who's just on an opiate medication. And when I say other things, I don't mean benzos, just so you know. I mean anticonvulsants, antidepressant drugs, all this stuff. Once you're in chronic pain, you got to treat it in different ways other than just opiate medications. That's a whole nother talk, but I would want to see that if I'm involved in reviewing charts. I would want to see other stuff. And every time, now here's what the CDC says, and this is what the state of New Jersey says. Every time you give an opiate, you have to counsel the patient on addiction. Right? Now, how many of you guys have EMRs here? Okay, the far majority of you. Do you have like that quick text thing? Right? Like you can just, I have dot opiates, and then a quick text says, I've reviewed with my patient the risk and benefits of these medications. I talked to him about the potential of coming off these medications and reviewed the addicting quality, blah, blah, blah. And every time I write an opiate, I do dot opiates, and it's right in there. It says that I've had this discussion. Every time the script goes out, I say to the patient, do you have any issues we need to talk about? Are there addiction? Are these medications? And I document it. Quick, easy, done. Now, what I see more commonly is people walk away with an opiate and no one documented a thing. That's a problem. All right? Every time you give an opiate, one, you must have a diagnosis that requires an opiate medication, right? And that you have addressed addiction with that patient. Yes?
Is that every time you write the script or every time you see the patient? I mean, what if your patient's on long-term, stable, they're on their every 3 months, they're not declaring them, but you're having to pick up the script each month, they're not really seeing you, picking up the refill, they're on a stable visit.
So, I mean, obviously to have a conversation with a patient like this, it needs to be face-to-face. So whenever you see that patient, you would make that, that quick text or whatever. There's an easy way you could do it too. We started doing this. We hand out addiction handouts to our patients. So every time they come in, and they get an opiate script in between, you can give them a little handout saying, just so you know, if you think these medications are a problem, let me know, and you give the handout to the patient. So that's an easy, quick thing to do too. I know it sounds excessive. I hear you. But this is the environment we're in right now. You want people to say, if you ever get audited or anything like that, you want people to come back and say, you did everything you could to prevent addiction for this patient. And they're relatively easy things when you think about it overall. Okay? Remember that you're going to be measured against your peers, whatever that standard of care is. Okay? Opiate agreement, you guys, you can have mine. Sole provider of the medication, can't sell, trade, get, or receive. You agree to urine drug test. Listen, I told you before, I could pee anywhere. I'm sorry. You walk out on a drug test, we're done. I don't care if you've got to pick your kids up from DIFUS. You leave without the drug. Thank you. It's getting long. I'm losing some of you, right? I hear they're in DIFUS right now. But you have to pee before you leave. Done. You walk out. We're no more opiates. I'm not telling you to discharge the patient. I'm telling you, cut them off. You're done. Right? You got to do it. No 1, 2, 3 strikes, you're out, guys. Those days are over. Right? I've said that for years. They're over. I went to lectures. Oh, the first time, the second time, the more creative I give it to them, right? A bird flies in and takes my pills and flies out. I mean, come on. Right? Those days are over. You have to think, you want to treat patients, you've also got to protect yourselves, right? Pill counts, very valuable. Now, I have seen issues with drug testing before, and I told you before, it's a whole lecture in and of itself, right, where we could have metabolism issues with patients, and I've seen it. So I've seen a drug test come back, and they turn out to be a rapid metabolizer of a drug, which means it's out of their system right away, and their drug test is negative. I've seen that. But what I'll do, if I'm thinking that could be the case, obviously I'm going to get a genotype testing on the patient. But the other thing I'm going to do is bring your pills in. Bring them in. Let me see them. Now, the problem is you can rent them on the street. And when you rent them on the street, they were going to be 3 different types of Percocet. There's Endicet, they're actually IR, and they're coming in like, here they're all there. And you're like, well, there's 3 different types of Percocet in here. And I think this is morphine, right? Guys, addiction is not our biggest issue. As much as we want to make this, and I mean, our biggest issue is diversion. The people